Hello and welcome to our new topic. Today's lecture focuses on drugs used to treat depression and mood disorders. Mood disorders represent a major burden of disease globally and affect emotional, cognitive, behavioral, and biological functioning. Pharmacological management is not merely symptomatic treatment. It involves long-term modulation of brain signaling systems and neuroplasticity. Understanding antidepressants and mood stabilizers therefore requires understanding brain neurotransmission, neuronal circuits, and adaptive changes in receptor systems over time. So, let's start. The learning objectives are shown. These learning outcomes are structured to build understanding rather than memorization. We will move from basic brain function and neurotransmission to drug action sites, neurotransmitter systems, receptors, and neuronal circuits, and finally integrate these concepts into the pharmacology of antidepressants and mood stabilizers. The aim is to understand why drugs work, not just which drugs are used. Mood disorders are defined by pathological disturbances in emotional state, ranging from persistent sadness to pathological elation, or alternating states of both. Clinically, they include depressive disorders and bipolar disorders, while anxiety disorders often overlap with mood symptoms. These conditions are not purely psychological. They reflect underlying neurobiological dysregulation of neurotransmitters, circuits, and neuroplastic mechanisms. Two major biological models explain depression. The monoamine hypothesis proposes deficiency or dysregulation of serotonin and norepinephrine systems. The neurotrophic hypothesis emphasizes reduced brain-derived neurotrophic factor, BDNF, impaired neuroplasticity, and neuronal atrophy in limbic and cortical circuits. Modern understanding integrates both. Monoamines regulate neuroplasticity, and antidepressants restore both neurotransmission and synaptic structure over time. Depression results from dysregulation in interconnected cortical limbic circuits involving the prefrontal cortex, hippocampus, amygdala, and brainstem nuclei. Altered monoamine signaling leads to impaired emotional regulation, motivation, cognition, and stress responses. Antidepressants act by gradually restoring network stability, not instant mood elevation. This slide represents the full neurotransmission cycle. Drugs can act at every step: precursor uptake, synthesis, storage, release, receptor binding, reuptake, enzymatic degradation, and presynaptic feedback regulation. Antidepressants primarily act at reuptake transporters, monoamine oxidase enzymes, and receptors, as marked within the box. Monoamine pathways illustrate how one transmitter system can produce diverse functions depending on anatomical distribution. These amines regulate mood, cognition, motivation, pleasure, reward, and movement. This explains why mood disorders often overlap with motivational and psychomotor symptoms. The dominant pathway for mood disorders is serotonin and norepinephrine, while psychosis relates mainly to dopamine. Serotonin and norepinephrine receptors are widely distributed and functionally specialized. Inhibitory and excitatory receptor subtypes allow fine regulation of mood, sleep, appetite, cognition, sexual and autonomic control. Antidepressants modify signaling across multiple receptor systems simultaneously. Different serotonergic and adrenergic receptor subtypes mediate distinct physiological effects. Therapeutic benefit and side effects both arise from this receptor diversity. Drug selectivity determines clinical profile, tolerability, and safety. Antidepressants are classified by mechanism. TC as inhibit reuptake of norepinephrine and serotonin. SNRIs inhibit both transporters. SSRIs selectively inhibit serotonin reuptake. Monoamine oxidase inhibitors reduce monoamine breakdown. 5-HT2 antagonists modulate serotonergic signaling. And heterocyclic compounds act through mixed mechanisms. In short, this classification reflects mechanism, not just structure. Mood stabilizers are drugs which play a supportive role by preventing mood swings after the dysfunction is stabilized. They include lithium salts, some anti-epileptic drugs, and some atypical antipsychotics. These agents stabilize neuronal signaling networks rather than simply increasing or decreasing neurotransmitters. Even herbal agents such as St. John's wort demonstrate monoaminergic modulation, showing convergence of mechanisms across pharmacologic traditions. This slide shows the mechanisms of action of various antidepressants and compares them. Monoamine reuptake and serotonin receptor activation is responsible for therapeutic effects emphasized in blue box, while alpha-adrenergic, muscarinic and histamine receptors explain side effects as highlighted by red box. Antidepressants increase synaptic monoamines, but their clinical effects are delayed because therapeutic benefit depends on receptor adaptation, gene expression changes, and neuroplastic remodeling. This explains delayed onset of action despite immediate biochemical effects. Adverse effects arise from excessive monoaminergic stimulation. Norepinephrine excess produces autonomic and cardiovascular effects, while serotonin excess causes gastrointestinal, neuromuscular, and sexual dysfunction. Therapeutic benefit and toxicity reflect the same biological systems. Blockade of muscarinic, histaminergic, and alpha-1 adrenergic receptors explain sedation, anticholinergic effects, weight gain, and postural hypotension. Side effect profiles are predictable based on receptor pharmacology. TCs cause coma, convulsions, and cardiotoxicity in overdose. SSRIs cause withdrawal syndromes and drug interactions via CYP inhibition. Serotonin syndrome represents toxic serotonergic excess. These toxicities reflect pharmacokinetics and receptor pharmacology. Antidepressants are used beyond depression because monoamines regulate multiple CNS functions. Pain modulation, anxiety disorders, OCD, PTSD, sleep disorders, and addiction all involve monoaminergic circuits. Lithium is a true mood stabilizer, not an antidepressant. It stabilizes neuronal excitability, intracellular signaling, and second messenger systems. It produces long-term stabilization of mood circuits rather than acute neurotransmitter elevation. Lithium alters intracellular signaling pathways, inhibits IP3 signaling, disrupts G-protein coupling, and modifies neuronal excitability. Its action is intracellular and network-based rather than synaptic alone. Lithium toxicity affects neurological, renal, endocrine, and cardiac systems. Its narrow therapeutic index makes monitoring essential. Adverse effects reflect its systemic ionic and intracellular actions. These references represent the core authoritative texts for CNS pharmacology. Students are encouraged to use them not for memorization, but for understanding principles. This lecture serves as a conceptual framework upon which all future CNS pharmacology topics will build. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!